Beautiful. So now I'm just going to hand over to Debbie. Once again, can I remind you all, please keep your microphone muted so that noise from your home or office doesn't interrupt the recording. If you do have a question about something that you particularly don't understand or need clarification, quickly unmute yourself and ask your question, or you can wait until the end when we have a little bit of a Q&A session. Thank you so much. Over to you, Debbie. I will make you the host.
Thank you. Let me push. Oh, host disabled screen sharing. Let's try again. Screen sharing. Here we go. All right. Well, thank you so much for inviting me and for so many people sharing their lunch break with me. I appreciate it. And I hope that I can answer the questions that you have. Sometimes I know it feels really overwhelming to see a report with lots of numbers in it. So hopefully we can get to some of the important things to look for. Just about myself, because we've always got to advertise ourselves, to remind you that I'm a psychologist, as I say to the patients, not a medical doctor, but the neuro part means that it's all about understanding brain function. So my study has been in psychology and I'm endorsed as a clinical neuropsychologist. I did work in the public hospital system for some time, as mentioned, but really for a very long time, I've been purely in private practice, which leaves me lots of time to do lots of really interesting and complicated cases. So for people who aren't familiar with what neuropsychology is all about, I just wanted to start with a short history. So neuropsychology started many, many moons ago with an approach to understanding brain function by looking at the outside of people's heads. So examining the bumps and lumps of the skull was thought to give information about what lay underneath. So that was called phrenology. Now, we know today that's completely inaccurate, but that's where humans started to develop an interest in wondering what was going on and developed the idea that different parts of the brain did different things. Over time, there became a greater interest in understanding specific parts of the brain and how that affected function when people were injured. So this is a famous case in our history where an individual had a workplace accident of a tamping gauge went through his skull, shearing the frontal lobes of the brain. He survived, but there were a lot of behavioural changes. And that was one of the first examples where we really started to understand that you could survive a brain injury, but not be the same person anymore. And neuropsychologists then were focused on developing tests that helped us understand what each, that evaluated specific localized functions of the brain. So the purpose of neuropsychology, particularly up until the early 70s, was very much about localizing an injury and how it affected someone. But we were very soon put out of business by modern radiology that made it obviously quicker and cheaper to do a brain scan, and far more accurate, of course, to do a brain scan to see if there was a lesion. So in that sense, neuropsychology had this big change in its focus. Oh,
can I just ask, a couple of new people have joined. Would you please mute your microphone? That causes the feedback.
Thank you.
Vignesh, please mute your microphone.
Anyway, good, thank you. So yes, so at the risk of being put out of business altogether by the fabulous radiology, we needed to return to our roots and think about not just the neuro part of neuropsychology, but the psychology part. So there was a bit of a renaissance of going back to the psychology bit in terms of trying to quantify human behavior and thought on our psychological tests. So particularly as we've moved in, we've followed the American literature to become more litigious, there has been an increasing focus on understanding the psychometrics of the tests. So the tests themselves, what they measure, and what are the statistical properties of them, and how that tells us something about what we're dealing with, which sounds very complicated. So our job is to make that more understandable for you. So why do we love the numbers so much? Because you've probably noticed when you read a neuropsychology report, there's a lot of reference to all these scores. So the fundamental purpose of the neuropsychology test is to objectively evaluate cognitive function and understand how that relates to an actual or reported brain injury, neurological disorder, or psychiatric condition. So we use our tests to answer lots of very complicated questions about people. So we have to think about, what was the person like before the event? How are they functioning now? Are there actually any cognitive deficits? Because sometimes people complain about what they see as deficits, but it may be something that happens quite frequently to other people. So it may not actually be an objective identifiable deficit. We ask then, how does this relate to what we know about the actual injury? So is the severity of cognitive dysfunction that we're seeing on our tests what we would expect given the research about the known effects of that type of injury as shown on the tests? And we also think about, is the level of performance out of the ordinary compared to what we know about other people on the test? So psychologists as a whole, but neuropsychs in particular, therefore come from this strong research position where we take our test scores very seriously. We take the scores and we compare them to the normative data to arrive at the answers. So normative data means that when a test is developed and ultimately published, the test developer collects data about thousands of people performing on that test. So that's how we know. So when we say, oh, this is average, or this is, normal for this group, we base that on the research information about the test in question. So some of you I know are probably medically trained, and I can see there's some psychologists as well. So one of the things that's really important that you may be familiar with is the idea of a normal curve. So most, but not all, tests have a normal distribution. The blue part is that kind of middle bit, the average bit. A lot of people on most tests fall in that average range. Less people score in the higher and lower ranges that are green, and even fewer people are in those yellow tails. Now, some people who are I guess, highly educated and super intelligent will fall in the upper range of the yellow. Some people who have intellectual disability or who have a significant brain damage will fall down in the lower end of the yellow. Lots of people fall in the middle. And I'm going to talk about that. That upsets people a little bit as well, because often our client, the people that we assess, feel very strongly that they were never average, that something about them was super special and they weren't average. They were never average and they're upset about being average now. But I'll come back to that. So for your general knowledge, common tests whose scores are normally distributed, so they use that curve that I just showed you, are the Wechsler Adult Intelligence Scale, the equivalent scale for children, and the Wechsler Memory Scale. The important numbers that you need to know from that is when the information from those tests is summarized into a score, the indexes have a mean of 100. So the average is 100. An average IQ, for example, is 100. But there's a standard deviation of 15. So that means that scores 15 points either side of 100 are also essentially average to slightly above and below. Subtest scores, so each of the intelligence index scores are made up of little subtests, so they all add together to make an index. They have a mean, they're on the same distribution. They have a mean of 10, standard deviation of 3. And we take all of the scores that we talk about and we translate them usually into some kind of scale like this. So that in a psychology report, you might see so-and-so scored in the low average range, 18th percentile, low average. So this is the table that most people use. So you'll see the middle column says WAIS, W-A-I-S 4. That's for the adults. But over on the other side where it says WISC, W-I-S-C, this is the children's test. So a new version came out a few years ago that changed the descriptors for the children's test. And so if you're looking at a pediatric assessment, the words are a little bit different. So instead of saying they have borderline intellect or borderline memory, you'll see them use the word very low. It means the same thing in terms of where they sit in the population, but the name is just changed in that test. So that is probably an indicator that sometime in the next few years, the adult one will probably change as well, but people will put that in their reports. So in a general sense, we just to signal to you that there's research involved in all of this, I've just plotted some very basic results about the intelligence scale in adults, and I've got, you'll see this blue straight line on the 100, so that's an average sort of score. And then the coloured lines reflect what research groups, this is just from the manual, research groups show. So we can see people with, the grey line is major depression. So we can see that major depression doesn't usually significantly affect intellect. ADHD is the yellow one, so attention deficit disorder. That might decrease in some areas, but not too bad overall. People with learning disorders, specifically a reading disorder, are the blue line, so that's a bit lower. And the one that we are interested in, because we find this, we're coming across this the most in medico-legal reports, is the traumatic brain injury. So that's the orange group. So they're, as you can see, much lower down. So this is a pattern that we're looking for. If someone is saying, I've got significant cognitive effects from a significant brain injury, this is the kind of pattern that we're told by the literature to expect. Similarly, just as an overview, you can see here, this is on the general memory test, so the WMS memory test. All of the other groups are up in the 95 to 100 range, but the moderate to severe traumatic brain injuries, people with organic brain injury, are performing much lower. So we bear that in mind when we're thinking about our test results and what we expect of people in terms of performance. The other score that you might see in a report is something called a confidence interval. So I've just given you one just from one of my reports. So we've got down the bottom is the little table. We've got a WAIS-4 index, and we've got the name of the index, so verbal comprehension index. We've got an index score. So the score in this case is 76. So again, mean of 100, standard deviation of 15. And that gives us the percentile and the name, the label, which is borderline. But you'll see this other set of numbers called 95% CI. And I wonder if you've ever kind of wondered what that's about. So that score is an interval or a band around that number that recognizes at its heart the imperfection and variability in both human performance and the actual tests. So it's a little warning to remind us that the person's score was 76, but it most likely falls in this 71 to 83 range. So we take into account the fact that the test itself mightn't be perfect. If they did the test on a different day when they'd had more sleep and more coffee, they might perform a little bit better. Probably wouldn't be a lot different, but a little bit. And what that statistic means is if we repeatedly did the same test, 95% of the time, the score would be in that range. The thing that's important that your psychologist has to think about when they're choosing their tests is that these confidence intervals are impacted by test reliability. So if a test has a lot of error in it, if people can get wildly different scores from one day to the next, that is reflected in the confidence interval. So they're much bigger and wider. So the score that they're getting, if they're a less reliable test, will have a much bigger confidence interval, so that the next time they do the test, they might get a completely different answer, a different score. And that might just be a reflection of the error rather than a change in performance. So the job of your psychologist is to either be very careful about the quality of tests that they choose and be open about the fact there is a confidence interval, or report that they're using a less robust test. So occasionally, I personally like to choose tests that I know are going to be the best we've got, but sometimes for whatever reason, I need something different. So I would mention that this is perhaps an observation rather than a really strong, robust score, so that we put less emphasis on something that is less reliable. So when you see something with the confidence intervals like that, you can see that the score, the index score, is kind of in the middle of them. So it's just, you've got to just think that there's a little band around that number that takes into account the fact that things change from day to day. And that's another important thing that we have to take into account too, because in our medico-legal work, we get asked this question a lot: what happens when the person does the test again? So in a test where the confidence intervals are not too wide, you would expect to get a score that is kind of in the same range as last time. There are calculations and statistics that we can do to work out if a score from one occasion to the next is different. And that will take into account what we know about the test and how consistent performances tend to be. For the psychologists, I know that's not the right word, but we're going to just use that. So this data should influence our test selection and the level to which we can rely on the results that we get. Another question that people often ask me is, well, you didn't know the person before. How do you know what they were like? And that's a really important question. And it's often the first thing the clients say to me. And we do that by a whole lot of things that, again, someone's doing the vacuuming.
Excuse me, D, would you please mute yourself? D, the person who is D, would you please mute your microphone? Actually, Debbie, you're the host.
Oh, can I?
You can mute that person. If you go to click on participants down the bottom. Oh, it looks like they might have done it.
I think they've done it. Okay, I'll keep going.
My apologies. Thank you.
Thanks. All right. So we have to look at a whole lot of information to see how the person was before. And we take into account what the research says, and the research says there's a whole lot of variables that tell us how the person functioned before they had their injury. And there are things like their age and their education level, the kind of occupation they did, their race, that's included in the American data, I have to say it. And then we have some tests that are of skills that are relatively resistant to brain injury. So that's a reading test called the test of premorbid function. So very cleverly named. So we take all that information and we put it all together into an algorithm, which is too complicated for me to do by hand. And that helps us predict the previous level of intellect and memory. So how the person was before the event occurred. And notably, it also reflects the distribution of IQ. So lots of people fall in the average range. And that is certainly something that people often argue with me about my reports. But, you know, I can only give you the information, and that things changed. You know, 20 or 30 years ago, it was perhaps unusual for people to go to university. These days, the government policy has changed towards education, and that a lot of people now get a 3-year type degree. And so that means that even though people have had some tertiary education, they're not necessarily outstanding. That's average. All right, so then we've got to think about, how do we assess memory and intellect? A lot of people balk when we say the word IQ. People don't like IQ, but it's just a summary to tell us which test we're talking about. Because as neuropsychologists, we understand, we want the best, the strongest, most robust measure of cognitive functions. And as it happens, the IQ test has a lot of the things we want to know about. So it has things like verbal skills, non-verbal thinking and reasoning, attention and concentration, and processing speed. So although it then all adds together to make an IQ, which some people don't like, as neuropsychologists, we're looking at the components as well. So the other good thing is that when that test was normed most recently, it was data was collected at the same time about the Wechsler memory test. So it's a matching memory test. And that has looks at both memory for words, auditory memory, and pictures, so visual memory. And the great thing about that, so when the research is done for us, it tells us what we need to know about, in the general population, if someone has an IQ at this level, what do we expect their memory to be? And then if we assess someone and their memory is not where it should be, we can tell that from the test. And that becomes really crucial information that might relate to an injury that they've had or a disorder that they have. So normally, well, there's been a move in recent years, I've noticed, to people actually reporting the scores. Some psychologists and neuropsychologists are reluctant to actually put scores in their reports. And I know that there might be some amongst us, you might have noticed that. I think I personally have the view of it's good to be transparent. It also stops people subpoenaing me all the time. And it also means that I'm giving you the reason. I'm giving you, this scores this, they're average on everything, that's the result. So you can see for yourself by me putting the scores in the report. But just putting scores in a report doesn't tell us anything. You're not the expert. Well, you might be, but we don't expect you to interpret what they mean. That's our job. And so the other thing that we report, which is where people get a bit caught up and confused, is whether the differences between the scores mean something. And it's no good to just eyeball the data, and that's the term that used to be used, and that was what I was trained to do. Just look at the data and say, oh, that's a bad score. The research has improved so much over the last few decades that we actually can answer the question of, are these two scores different and do they mean something, with statistical information. So I'm going to give you an example. Particularly if you you've practiced for a long time, you might have seen psychology reports that talk about a difference between verbal IQ and performance IQ, verbal and non-verbal. So the names have changed over time, but I've given you an example here. So we've got a verbal index of 100 and a performance index of 85. And you look at them and you can see, oh, hang on, that's a standard deviation difference. So that must mean something. And it does, because it's statistically significant. So the stats say, look, these two numbers are different. That's what they mean. But then we look at how often does a difference of that size happen in the population. So we have to think, although 15 points sort of probably means something, is it something that's uncommon? And in this case, the base rate's 13%. So that means 13% of the population has a difference this large or greater. So does that mean that they've got brain injury or not? Do 13% of the population have brain injury? Possibly not. Then we look at another difference, which is, for comparison, I've just made the numbers up, but where we've got 100 on the verbal and only 77 on the non-verbal. So there's a 23-point difference. And when we look up the base rate of that, it's less than 5%. So that says less than 5% of the time somebody is going to have a difference this large. So that is very uncommon, and that really means something. So when I've said in the report, these two things are really different and it's very uncommon, it means something. I should tell you what it means, but the important thing is that it really means something when the difference is that large. But you couldn't have known that just by looking at the information. To confuse you a little bit, I've got another one about processing speed. So the comparison here is verbal intellect versus processing speed. If there's one thing that's the canary in the coal mine about the effects of brain injury, it's processing speed. But it also gets affected by things like medications and stuff like that. So we look very strongly at whether someone's processing speed is impacted. So in the first one, it looks like a big difference. So it's average versus low average, but the base rate of a difference like that on these two indexes is pretty common, 17%. So it's unlikely to be a signal that we need to worry about. But when we look at a VCI, a verbal intellect of 100, but the processing speed is in the borderline range at 77, that's less common. It's less than 10%. So the frequency with which that occurs is only about 8%. So we'd be starting to say, oh, something's going on. But if it was even lower, if the difference was, as I've shown at the bottom, 100 versus 73, that base rate's less than 5%. Now, and that would really mean something. So you get a report from me saying there is a clinically unusual weakness of this, and that relates to whatever, it may or may not relate to whatever has allegedly happened to the person. I made this example to show you that you'll notice that in the bottom two, both of the PSI scores are in the 70s. So what we call the borderline range. Sometimes in reports, people just go, oh, here's all the average scores, here's all the low average scores, here's all the borderline scores, like that. They sort of list them out. What I want to show you is if you do that, you don't know about the comparison of those scores. You don't know if the difference is something that is really important or not. Just because PSI is borderline, it means something different if the base rate is sort of 8% versus 5%. It's not a big difference, but it means something different. Similarly, thinking about memory, if we've got average general ability or IQ versus a delayed memory index, it's not uncommon. 10 to 15% of the population have a low average memory in the context of average general ability. But if the low average score is a bit lower, that is 80 rather than 85, suddenly that is a 5% base rate. That's quite uncommon. And that would be a signal where we'd say this is a very significant memory impairment. It means something, that it's that different and that uncommon. And it's even worse when it moves into the borderline range of a 3% base rate. So the take home from this is the base rates mean something. So the base rates tell us how often a difference happens in the normative population. And I report it like this: if it's more than 10%, it's there. It might be two different scores, but it's not clinically unusual. 5 to 10%, I start to be saying, well, it might be a bit of a problem. 5% or less is where you get a really strong result where I'm saying this really means something. These differences are uncommon in the standardization sample, so it's clinically meaningful. And then I would go on to say, well, is that, I've gone the wrong way, related to the injury that they had. So they had an injury. Would it be expected to cause this level of dysfunction? A by-the-by comment that subtest comparisons, so when people talk about individual scores rather than indexes, so each of the indexes is made up of 2 or 3 subtests, so they're banded together, and that gives them more robust psychometrics. So that's less variability. So it's not good to focus on the individual subtests because they're less reliable, if you like, but they might illustrate a point. So I might say something like, this person was distracted and not listening to the instructions, so performed poorly on this subtest, and it was therefore an unusual weakness, less than 5% base rate compared to everything else. So that would explain to you something went wrong, and that's a very different score, and that's why. So we're looking for a pattern of clinically significant strengths or weaknesses. So as I mentioned, PSI, processing speed, is really important in lots of disorders. Poor memory can be very important. And we also take those scores and we compare them to the predictions based on the test of premorbid function. So we say, compared to how we think the person was before, how are they now? And again, we can give you a base rate of difference. We can say, well, usually in the standardization sample, this is how often this happened. So that does or doesn't mean something about whether there's been a change. And then I correlate that with the history. Is the person saying there's a change? Is the injury such that it would have caused a change of that nature? I want to just mention about other tests. So many of the other neuropsych tests are also reported on the normal distribution. So those percentiles that I mentioned would also apply. So things like some aspects of executive function, processing speed, verbal memory. But there are some tasks that are very skewed. So what we know is on confrontation naming, for example, most people get almost all of them right. So there isn't enough of a distribution to have a normal distribution, that some people are in the middle, some are above, some are low. So often those are reported without much of a score, but they might say within normal limits. So it's just it's just a reflection of that. Often those skills are a bit more binary. You get it or you don't, or you have that skill or you don't. So it's not as so there's not as much variation. Now, just to confuse you, so we've talked a lot about index scores. I just wanted to mention that it can be confusing because you often get both of these in your neuropsych reports and your other psychology reports, is that some tests use T-scores rather than index scores. And a T-score has a mean of 50 and a standard deviation of 10. So we talk about a score that is greater than 65 as being clinically significant. So you might see me write something about a personality test. Mr. X reported a high level of depression, DEP equals 73. So that's above 65. So I'm saying that means something. And a score here, so sorry, silly. So it's up in this very high range. It means the person is reporting, compared to other people, lots of symptoms. Now, the other thing that sometimes you see in a report are actual raw scores. So there might be two reasons why you'd see one. One is to illustrate a point. So Mr. X couldn't learn, well, struggled to learn the word list, and after 5 trials could only remember 5 of the 15, and that's the whatever percentile that is. Or I might say he easily learned the words. By the 3rd trial, he could remember all 15, and that was the score. Now, usually the raw scores aren't reported because they don't mean much without a percentile rank. So they don't mean, so me saying the person only got 5 words on the list, you're like, well, I don't know what that means. Is that good or bad? Is that good for someone with low education maybe? Is it bad? So usually you don't want to be looking at raw scores. Normally they're turned into a percentile to tell us how the person ranks compared to other people. Very occasionally, the score itself might be important. So it might be a test that doesn't have percentiles. So I might say something like, Mr. X could only recognize 23 of the 50 pictures that I showed him. That's in the random range, and that's an unsatisfactory performance on this task. So obviously your psychologist would offer an explanation of what that means, but sometimes we include the score so that the next psychologist knows what we're talking about. So I usually put a lot of scores in my appendix because I want the next psychologist to be able to analyze them and understand them. I personally don't mind if you ring me up and ask me questions because I understand that this is kind of, it's hard. My job is to try and make it useful and meaningful. But if I failed to do that in the report, obviously, I'm happy for you to contact me. So I might pause there to allow the opportunity for maybe some questions if anybody has any.
Thank you, Debbie. That was really interesting. That was fascinating, actually. Just going to reclaim hosting. Really, really good. I very much enjoyed that and learned a huge amount myself. I have a quick question for you, and that is a neuropsych assessment, and I have seen a lot from lots of different practitioners. They can take 3 hours, sometimes even longer, and particularly if the person does have a brain injury or a mild or otherwise traumatic brain injury. How do you look when you, how am I going to put this? So when you put the report at the end, that's 4 hours of quite grueling concentration for that person. Is there an adjustment made in the report for the fact that that particular assessment is quite grueling and isn't what they're normally doing?
Sure. Well, there's a few things. The first is that when the research is collected, it is on the equally lengthy tests. So people do go through. So in some ways that's reflected in the way that the test is scored. The second thing is that, yes, well, I tell people to keep all day free. Sometimes we need all day. But I'm also a strong believer in taking breaks. So we don't rush through because I want to go to lunch. We stop and take breaks, which probably better reflects what a real day looks like for someone at work, you know, a morning tea break and a lunch break. But yes, it is often a greater challenge than the person encounters in their life. But I also consider that if the question, and frequently the question is, can this person go back to work? And so we have a joke at our office, which is the truth comes out at 3 o'clock because we start at 9, because that's it. I think it's important to see what happens when the people get tired. If what they're saying is, I had a mild brain injury and now I can't concentrate long enough to work a full day, let's see what happens. And so I often talk about in the report, you know, as the day went by, the person was visibly tiring and And I can look at my results and say, well, also we distribute the tests throughout the day so that we might do some memory and speed of processing early in the day, and we do some again later in the day. So I can look at them and see, is there really a difference in the way that they're performing as well? So sometimes subjectively is one thing versus what really happens is another. So that's the way we try to do it. We recognize that it's abnormal and that people often complain they need days to recover.
Yes, I've heard that too. One other quick question, and I'm sure somebody else will ask this if I don't. What's your experience been, given that we've been through COVID, but also you might often be asked to assess somebody who is living remote or in a regional area. What's your take on performing a neuropsych assessment via telehealth platforms?
Oh, I'm probably the outlier, but I generally don't do it because my concerns for Medicolegal are that I'm not in control of the environment. I don't know who's in the background. I don't know whether they recorded the last one they did and they're looking at their notes or anything like that. So I'm a bit of a stickler for, I like to see the person face to face. I think that that's important because, the way they come and present themselves is important. I had the experience, I was asked to do some overseas assessments during COVID, and people honestly just turned the camera off and went and had a sleep for an hour without telling me and things like that. And so it was very, very difficult. The other thing is we use manipulatives, so they have to put blocks together. A lot of my stuff could be done online, but I really don't like the lack of control of the environment.
Right. That's something I do hear from other neuropsychs. Is there anyone else who would like to ask a question of Debbie?
I saw there was something in the chat.
No.
Yes. Yes. Okay. The big question that everybody asks. So I'm not going to give away all my secrets, but so the question is, how do we know that the person's responses are authentic as opposed to exaggerating their impairment? And people can exaggerate their impairment for lots of reasons. Sometimes it's financial, sometimes it's all about having someone care for them, all those sorts of things. But, sorry, I see that was a direct message. That's why you can't see it. So the thing is that because ultimately our conclusion is about brain injury or brain effects, we absolutely are very worried about whether the person is doing their best, because we do not want to be saying they're injured when they're not. We don't want to understate it if they are. So all throughout the assessment, so all throughout the day that they come to see me, there are tests sprinkled throughout that are designed to capture that. It is also the case that neuropsychologists are very well trained to spot unusual behavior. We see real behavior all the time. It's very easy, not very easy, but it's frequently the case that the red flags go up quite early when people are exaggerating, because there's a set of behaviors they often engage in. And we might bring those tests out a little bit earlier in the day, but they're definitely sprinkled throughout, and a proper medico-legal assessment should not overlook that at all. That is something that's crucial.
Great. Look, that was absolutely true. Oh, look, another question.
Comorbidities. Okay, so the question is, what do we do about pre-existing comorbidities? And that is difficult. It depends what they are. So if they have a comorbidity of, say, a learning disorder, then we probably have a pretty good guess about how that's going to affect them cognitively. If it's more of a psychiatric disorder, it's often harder for us to anticipate how that might have affected cognitive function. So basically what we do is collect as much information as we can. We may interview others. We may ask if they had problems during school. We might get the school reports. We might get previous psych assessments. those sorts of things. I'm always asking for more. So we look at those as best we can. It's surprising how many people have had some kind of cognitive assessment in their life. So we get that. And then we just try to make some kind of useful comment about, I would have expected they would have been like this, and now they're like that. And whether or not that's related to the reported event. It's imperfect, I know. Post-concussion. Oh, yes. I don't know. Injury impact. Okay, so the pre-existing, if it's not, okay, so the follow-up question is, if the pre-existing comorbidity wasn't previously diagnosed, could it be sort of mistaken? And how would we know the difference between injury impact? Look, we don't know 100%. I like to think that we're reasonably good at taking that history fairly carefully. Often people will sort of say one thing, but then when we ask a few more questions, it turns out they were always having problems with a certain thing. And we'd also be looking at, does the pattern of performance look like the injury that they say they've got? Are those things consistent? And I think all of that together, it's not perfect. I'm not saying we're perfect. I'm not saying we're never wrong, but I think it contributes more information at the end of the day than when we started. The other question that we've asked is another controversial one. Do I have any comments about the post-concussion syndrome? Is it real, or is it diagnosis provided to reassure a patient? Look, it's a bit of everything. The evidence is that in the early stages of recovery, so the first weeks to the first few months, people may well have demonstrable post-concussion syndrome. When it goes on longer, there's the evidence from the literature is normally their cognitive deficits have resolved. And that's usually what we see on testing. But what hasn't resolved is often other things. So there's a lot of evidence that that often it becomes, if you like, a highly somatic focus for the person, or they've got untreated depression or anxiety, and they don't, and they keep referring back to the concussion symptoms, the dizziness and headaches and those sorts of things, rather than and often there's another explanation. So it's multifactorial, and it depends about the time from the injury and what else is going on. We've lost you. Hang on.
There we go. Sorry, my fault. Saying some really great questions there. We're going to have to wind up coming up. We've almost gone an hour. That was fascinating. You were worried you weren't going to have enough material to fill it. That was really, really great. I understood that as a layperson. Gave me a greater insight into, what I see in my work and when I deal with clients about a neuropsych assessment. So that's really helpful to me, and I hope it was helpful to everyone else. It sounds like it was very, very beneficial. Debbie, thank you so much again for giving of your time and your expertise to MAG. We really appreciate it. And everybody, can I suggest that you actually subscribe to our YouTube channel, where you can then have access to all of these wonderful seminars for free whenever it suits you. They're really great to do as a training exercise with your team. You can find the ones on particular injuries, conditions, or specialists that you like, and use them all. So thank you so much, everybody. Have a great rest of the day. And thank you so much, Debbie.
Thank you. Bye-bye.